Can you see my screen?
We can.
Okay, good.
Perfect.
Wonderful. I'm just going to hide the video panel. Well, welcome everyone. As I said, my name is Anne Loeser, and I want to take a moment to thank Stacy and everyone in the ACE Collaborative for inviting me to speak today about patient-centered dosing. We'll be covering the following topics: the cancer drug dosage paradigm, dose escalation and the limitations associated with it, why dosage levels matter. Then we'll switch gears and talk about the Patient-Centered Dosing Initiative, or PCDI. We'll talk about the PCDI's patient and oncologist survey results, and then some next steps for our participants today to think about. And at the end, I'd be glad to take questions. The cancer drug dosage paradigm, the underlying premise behind which dosages are identified and administered, can really be summed up in 3 words. More is better. The idea is to administer the highest dose with the greatest toxicity as often as possible. That paradigm has been around for decades. Dose escalation methods used in phase 1 clinical trials were developed in the era of cytotoxic or chemotherapy drugs back in the 1960s. It's been assumed that both efficacy and toxicity increase with increasing dose. And by toxicity, we're talking about a measurement of the dose needed of a particular substance to damage a living organism. And just about anything in sufficient concentration or quantity can be toxic, even water. Phase 1 clinical trials measure toxicity and not efficacy as the primary endpoint. The most common dose escalation method that's used in phase 1 trials is called 3+3. And I can guarantee you that this slide will be confusing and that all will be made clear when you see 3+3 dose escalation in action on the next slide. Here's how it works. 3 patients are initially enrolled into a given dose group or cohort. And if there are no dose-limiting toxicities, or DLTs for short, which are severe adverse events, 3 new people are enrolled at the next highest dose. If 1 person develops a DLT, 3 new people are enrolled at that same dose. The development of DLTs in more than 1 of 6 patients in a specific group suggests that the maximum tolerated dose has been exceeded, so the next lower dose is considered the MTD, or maximum tolerated dose. That is as clear as mud, but I've spelled it out in case for future reference you want to look at this in writing. So let's see how this works. On the left-hand side, you see an arrow facing upward in green, and that represents a higher dose going up. In the 3+3 dose escalation, we start with 3 patients on the lowest dose. And that low dose has been extrapolated from preclinical models who took the drug. If there are no dose-limiting toxicities, 3 new people are enrolled at the next higher level. In this case, 1 person, the person in the middle, develops a DLT. So we cannot go up, we need to go sideways. 3 more people are enrolled, they do well. So we go up a dose. They do well, we go up a dose. And in this case, 2 people develop a DLT. So we have to go down, enroll 3 more people, and then we enroll 3 more people at that dose as well. And since everyone's doing okay, that becomes the maximum tolerated dose, or MTD, which is sometimes referred to as the recommended phase 2 dose, or RP2D. Once the drug is approved, it's gone all the way through all the clinical trials, and it gets to the clinic, that dose is known as the recommended starting dose, or RSD, and it's sometimes called the standard dose. That is exactly, in a nutshell, an illustration of how dose today is done in phase 1, 3+3 clinical trials. As you can imagine, there are limitations of this. It's based on the premise that the higher the toxicity, the greater the efficacy. It has small group sizes, doesn't take into account long-term treatment-related side effects. It ignores levels of drug efficacy that are associated with the lower doses we saw. It's not entirely relevant for the more modern targeted therapies where dose-limiting toxicities may not occur even at doses above the optimal biological dose. And by optimal biological dose, we're referring to the lowest safe dose that's associated with biological efficacy. And finally, and really importantly, patients' responses in the real world differ from those of clinical trial participants because people who enroll in clinical trials are subject to rigid inclusion and exclusion criteria. So the cancer drug dosage paradigm of more is better began to be questioned at the beginning of this century. The reason for that questioning is that in the 1990s, more than 41,000 breast cancer patients underwent a procedure called high-dose chemotherapy and autologous bone marrow or stem cell transplant. They had hoped that they would be cured by these really toxic levels of chemotherapy. However, in the year 2000, the New England Journal of Medicine reported the results of a major randomized trial of this for metastatic breast cancer patients, and it determined there was no survival advantage compared with standard dose chemotherapy. And that was when that paradigm seriously began to be questioned. Why should all this matter to us? Well, people with metastatic breast cancer are treatable, but we're not curable, and most of us will remain on treatment indefinitely. And I'm sure this is true for other metastatic cancers as well. As a result of toxicity-related side effects, patients have been known to visit the ER or hospital, be rendered incapable of receiving their treatment on schedule, experience a degraded quality of life. And although more data is needed, we have evidence that suggests that allowed lower doses of some MBC therapies can be as effective as the recommended starting dose and precipitate fewer and less severe side effects. Furthermore, lower doses may enable patients to remain on a working therapy for a longer period of time. This is a really key point. So rather than dropping a treatment due to toxicities, the treatment would be dropped because it's no longer working. It's good to know about lower doses, but what is really an allowed lower drug dose? Well, in the case of metastatic breast cancer, many drugs come in multiple doses as per the package insert. Some drugs only come in one dose. So if a patient is struggling on the recommended starting dose, they may have anywhere from no opportunity for a dose reduction all the way down to 3 lower doses. And we call those allowed lower doses once the patient has experienced a bad side effect on the RSD. The percent of the original dosage can go as low as 25%, which is pretty amazing. So here's an example of a CDK4/6 inhibitor or targeted therapy called Verzenio when taken as monotherapy. The RSD is 200 milligrams twice a day. If a patient is struggling on that, they're allowed a dose reduction down to 150 milligrams twice daily. If they're still having side effects, they could get a second dose reduction down to 100. And if they're still having a problem, they could go down to a third dose reduction, that's 50 milligrams twice daily. And you see that 50 milligram twice daily dose is only 25% of the RSD, which implies that it still has sufficient efficacy as to be prescribed under certain circumstances. Well, that's nice to know, but how effective are these lower doses? Here are 3 dosage-related studies: Verzenio, which we just saw, Ibrance, which is also a CDK4/6 inhibitor, and Xeloda or capecitabine, which is a chemo drug, In all three cases, an allowed lower dose was as effective as the RSD and precipitated fewer or less severe side effects. Interestingly enough, if you look at the second and third arrows under Verzenio, when taken as monotherapy in this phase 2 trial, the overall survival at 150 milligrams was nearly 21 months, and at the RSD, it was 17. Very interesting, that particular result. Now we're going to switch gears. We've talked about side effects. We've talked about dosages. Now we're going to talk about the patient-centered dosing initiative. Our mission is to enhance quality of life while maintaining therapy effectiveness by enabling patients with MBC and their doctors to identify the optimal allowed dose of treatment based on each patient's unique physical, circumstantial, and psychological factors. That's quite a big mouthful, but in a nutshell, we're really talking about a new paradigm. Instead of prescribing the RSD at the beginning of each new treatment and then reducing the dose when the patient has side effects, we are urging that the starting dose in clinical practice be personalized based upon the patient's unique attributes. What are these attributes? We call them patient-centered criteria. The first is the patient's personal goals and wishes. So if a patient has a daughter who's getting married in 2 months, they should tell their doctor about that. And they definitely won't want to be given the dose of a drug that will make them run to the bathroom with nausea or with diarrhea on that special day. Performance status, which includes other illnesses, age, mobility, and so forth. History of side effects from other drugs. Some people are just more sensitive to drugs than others. Current and historical blood counts, whether the disease is aggressive or indolent, whether there's organ dysfunction or CNS metastasis. The patient's body mass index may play a part. What about the patient's financial situation? So if they'll need additional medications or a referral to a specialist to deal with side effects, can the patient afford them? And finally, and really importantly, what is the availability of that patient's at-home care? So if a patient is wheelchair bound and there's no one at home to help them, is it really in that patient's best interest to be given the dose of a drug that will precipitate nearly uncontrollable diarrhea, at least in the beginning of treatment? The PCDI was founded by metastatic breast cancer patient advocates. Our current members, and I know you'll recognize many of them, are Martha Carlson, Janice Cowden, Julia Maas, Sheila McGlown, and myself, the founder. We are very fortunate to have an extremely talented advisory board of medical oncologists, namely Drs. Aditya Bardia, Mark Burkhardt, Kevin Kowinski, Mariam Lesberg, and Hope Rugo. And they have done a wonderful job in guiding us and making sure that everything we do is medically and ethically sound. Last year, the PCDI launched a survey for patients with MBC, and this year, we launched a companion survey for medical oncologists who had experience treating patients with MBC. The objectives in both surveys were identical: to understand the prevalence and severity of patients' treatment-related side effects, ascertain the level of physician-patient communication about side effects, increase understanding of the impact of lower doses on patient outcomes regarding quality of life, and importantly, to determine patients' and oncologists' willingness to discuss flexible drug dosing options with each other based upon the patient's unique personal attributes. The responses to these surveys are enabling us to advocate for future improvements regarding side effect mitigation and potentially avoidance. The patient survey results are in white font, and the oncologist survey results that you'll see will be in tan. We received 1,221 responses to the patient survey and 119 medical oncologist responses to their survey. An overwhelming majority, 86% of patients with MBC, reported experiencing at least one bad treatment-related side effect. We could not try to further define what bad meant because this is very individual. What one person might feel is a bad side effect might not be considered bad to another. Interestingly, more than half of the oncologists in the survey estimated that less than or equal to 50% of patients reported a bad side effect. So you could see that oncologists really underestimated the prevalence of treatment-related side effects. 1 out of 5 patients visited the ER or hospital. The oncologist estimate was close at 15%. 43% of patients with bad side effects had to miss at least one treatment. Oncologist estimate was 37%, again, very close. Nearly all, 98% of patients reported their side effects to their doctors, and in turn, 82% said they were assisted. Of the people who received assistance from their doctors, 2/3 indicated that they were given a dose reduction. Of the people given a dose reduction, 83% felt better, at least initially. Oncologists' estimate was that 74% of their patients felt better. And 23% of the oncologists said, you know, the results vary too much to generalize. 77% of patients indicated that their doctor asked about side effects at every visit, and every oncologist in the oncologist survey said they asked about side effects at every visit. So there's a disparity there. Back to that paradigm, is a higher dose always better and more effective than a lower dose? A little more than half, 53% of patients did not believe that paradigm. And interestingly, 85% of oncologists did not share that belief. They did not believe in that paradigm. The wonderful, encouraging news as well is that the vast majority of patients, 92%, and 97% of oncologists would be willing to collaboratively discuss allowed NBC drug dosing options based upon the patient's unique characteristics. Very encouraging. So what are we going to do with all of this information? Well, the PCDI wants to share its results with the FDA, and the time is right. And what I'm going to show right now affects all of us who have cancer. Right after ASCO 2021 last month, Dr. Rick Pastor, the director of the FDA's Oncology Center for Excellence, stated that the primary objective of phase 1 trials should be to determine a range of doses to be studied in subsequent dose-ranging phase 2 trials, rather than simply identifying the MTD. This is music to our ears. We'll talk a little more about that in a minute. The PCDI also wants to engage pharmaceutical companies regarding dosage level efficacy. We want to retroactively compare outcomes of patients in clinical trials who are given lower doses due to adverse events with outcomes of patients remaining on the MTD, and especially with regard to efficacy. So we want to get that data from completed clinical trials and build that comparison proactively into future clinical trial design, because efficacy data is important. So how does the FDA and the PCDI approach dovetail or fit in together? Well, there's the front-end aspect whereby dosage is identified in clinical trials. We saw that. There's the back-end situation once the drug's been approved and we as patients are sitting in front of our doctors in the clinic. But even once the FDA's direction is implemented and the optimal dose is identified in the clinical trial setting, there will still be patients in the real world who tolerate drugs differently from patients in clinical trials. We believe that getting it right at both ends is very important. So the next 2 slides, and we're almost done, we're going to wear 2 hats. On this slide, we're going to wear our patient hat. So what can we as patients do? Discuss patient-centered dosing criteria when beginning a new treatment. And even if that treatment only comes in one dose, it might be helpful when deciding upon what treatment to get next. Make the doctor aware of personal wishes and priorities throughout treatment. If there are side effects, speak with a doctor about the options to relieve them. And these are the most common: reducing the dose, changing frequency, trying a different drug manufacturer, because sometimes the filler may be what's causing a problem, obtaining medication for relief, switching treatment, or getting referred to a specialist. Make a collaborative decision with a doctor about what to do, but never reduce the dose or change anything about treatment without speaking with a medical team first. So now, what might be helpful for members of the ACE collaborative to do or know about as potential next steps if you're interested? Well, first, it's helpful to create a list of FDA-approved drugs for the disease and stage that you're interested in. And there's a sample at that hyperlink. Determine allowed dosages for these drugs. For the drugs that are available in multiple doses, look for studies and reports about the efficacy of those lower doses. Approach pharma for additional efficacy-related information, and, like we're doing today, begin making patients aware of their options. If you're interested, here are 5 very, what I find very intriguing articles on this subject. And I want to take a moment to thank all of you for your attention. If you would like to have additional information, please visit our website, therightdose.org, or email us at info@therightdose.org. And now I'd be happy to take questions.
Thank you, Anne. Honestly, that was one of the better presentations I've seen.
Thank you.
There were a couple of questions in the chat. If people weren't following the chat, I think Annie asked, based on the responses that you received from the oncology side of the survey, what types of centers were they all at NCI centers? And Julie answered that and said that yes, they were, which is kind of a great point. You know, 80% of individuals are treated at community oncology centers. So definitely making the broader oncology provider community aware of this.
We did have community representation as well from the community oncologists, so we were really relieved because we were worried about having at least some sort of balance there.
Awesome.
Good point.
Annie's got her hand up, and I just...
Yeah, I was just going to say that I think the NCI center thing is interesting because I think patients who aren't at NCI centers might have different experiences, like visiting the ER, or like I know of a phase 3 trial where 3 people are on it off label, and like the doctors can actually like adjust for dosage for the patient. So like there's a lot of dose escalation, dose reduction going on at NCI centers. And so I'm just wondering if that's showing up in the patient experience. Like if you're
it's not a lot of work. Sorry about
okay.
that. Take that off.
Did you have an answer to that?
Yeah, so we didn't ask patients at what kind of center they were treated. In retrospect, that would be interesting to know because that would be really interesting for a subgroup analysis, but we did ask the doctors about the type of practice, whether it was an academic institution versus a community setting. I'll tell you something interesting, just talking with our advisory board, even though the recommended starting dose is, the standard dose to start with, just about all of our advisory board members who are at a meeting, and they all work at academic, centers and NCI accredited, almost all, I think all of them actually have started patients on lower doses. And that's not unusual. And just about, it was like 80-something% of the oncologists had also started patients on lower doses. Now, when we talk about that, we also have to remember that there are medical contraindications that sanction the lower dose to begin with, such as renal or hepatic failure. So that's not a surprising statistic per se, but a lot of the oncologists also said they did it because the patient might not otherwise have been able to tolerate the standard dose, or the patient even asked for a lower dose.
Awesome.
It's a really incredibly important topic. I thought the part that I was really wanted to find out more about, and maybe it's too much for this presentation, is, you know, you're talking about targeted treatments and like things that are like enzyme targets versus chemotherapy or something like Herceptin, and if the dose, if the appropriate dose varies, whether it's a you know, toxic treatment or whether it's a targeted treatment. And I mean, I was talking to one researcher last month, and she was explaining that once you get enough in the bloodstream, you have to let people have their body to process, you know, the targeted medication. And there might be more than enough in the bloodstream that you don't need to keep on dose escalating if there's side effects. So I don't know if you had found anything in regards to targeted treatment, because you mentioned it in one of your slides.
Yeah, you know, the targeted treatments are interesting because some, like Verzenio, what we saw come in multiple doses, but Herceptin or trastuzumab can be set as a targeted therapy, and that's only available in one dose. You know, it's based on body weight, but the concentration is the same. So, you know, it's really not just, you know, whether it's targeted or not, but you know, endocrine therapies, by the way, only come in one dose. And I did ask one doctor why that was, and he said, typically, you know, the way that hormonal therapies work, they work differently than other, you know, types of drugs. And so that was, you know, his reason.
And that is in the US, because tamoxifen is actually, Decenzi has a lab based in Italy, and they've been looking at modified doses.
Yes.
Terry, you had your hand up.
Me too. This was a great and very timely presentation. I'm not in breast cancer. I've been working in lung cancer and around the KRAS mutation. And I saw that when they approved the drug recently, like just the end of May, for the KRAS mutation, FDA actually is tasking the pharma company with watching the dosing, and as far as escalating it, and like I don't exactly know all the nuances of it, but watching it, whether it needs to go up or go down. And so this seems to be like a brand new sort of thing that they're doing. I'm kind of engaged in this. And again, this may be way deeper than this conversation can go, so we may need to just connect offline. But what is it that I need to be asking, looking for, and encouraging so that we can kind of keep along the same track? As that's exactly what we need to be doing, watching for making it personalized.
You know, that's a great question. From what I've read, and I think it was in one of those articles on that page just before, there was a link to the FDA about what they're doing. And I think they want to gather patients and health professionals and actually work with them on how better to make this happen at what we call the front end in the clinical trials. And what I can do, I can find that link and find that excerpt and send it to you, Stacy, if you'd like. I'd be glad to do that. And the other thing, you know, as I said, we want to share the PCDI's results from 2 surveys with the FDA. But furthermore, what we want to do is we're going to ask the FDA if we could hold a workshop on this entire topic. And that workshop would not just be with patients and advocates, but also with health professionals and oncologists. So we're currently working on how best to reach out to them.
That would be fantastic. Loop me in on that, because I've done 2 of their OCE presentations as like the present thing, and they keep asking me, and I keep feeling like I'm supposed to be answering more, but I didn't know about your organization. So very timely.
So Terry, we'll keep everybody looped in. I have a feeling that there's other cancer groups and advocates that want to be part of it. So absolutely. Meredith had great. I'm just so impressed. This is like a year we finally figured out how to do the raise hand thing in Zoom. This is amazing. Meredith.
Yeah. Oh, thank you so much for this. It is just so sorely needed. Personally, I had a near fatal experience with immunotherapy, and then went on to a thyroid kinase inhibitor, but was started at the highest dose. And it was, just seems so illogical that my doctor would do that. And it hadn't occurred to me to say, gosh, can we start at a lower dose on this one and see how that goes? And, anyway, I'm wondering about your thoughts on how to get this information out to patients, because certainly in the community-based cancer centers, a lot of the docs are not going to be on this bandwagon quite yet, shall we say. So how do we do that? Have you guys thought about that?
We have. I mean, one of the things that we've been talking about is to create like an infographic for patients, very easy to understand. Because of everything else we've been doing, we have, we've sketched out some ideas, but we don't have that ready yet. And that would be for your BC, because that's what we know. But there's no reason once we have something that it couldn't be shared. And the other thing, maybe you don't have to depend on us to do this. I mean, you could look at the patient-centered criteria. You could, look at the drugs that you are representing, with your type and stage of cancer, and put something together as well. I would encourage you, though, before sharing something broadly with the patient community, have at least one or two oncologists look at it. And maybe what we could even arrange, as I think about it, like we have this amazing advisory board, we could always maybe pass it by our advisory board too.
Oh, sure, absolutely.
Question for you, Anne. What would be your willingness? And I think you're right. I think we need to kind of figure out the strategy before just sounding the alarm for all patients. But how would you feel about sharing kind of the structure and framework of your survey so that people could ask similar questions within their own community groups?
Yeah, that's great. So if you visit our website, rightdose.org, the results of the patient and oncologist surveys are there, with the questions. So you could actually go through not just the questions, but the graphs and charts showing the results and take from them what you will. And everything that we did in terms of compiling these surveys, we ran by our advisory board, of course, and we got IRB exempt determination for those surveys.
Awesome.
But yeah, visit us on our website. The everything's right there.
Kathleen.
Anne, thank you so much for this presentation. It was kind of blew me out of the water. Really, really good stuff, and so timely. So I'm on the I work with women who have ovarian cancer, and PARP inhibitors have been a big, and I know they are in breast cancer as well, but they've been a big win for ovarian cancer for the first time in years. Not for everybody, but there's an onboarding what we refer to as an onboarding process. And I'm just wondering how that fits into dose reduction. So we see women who are given the highest dose, right? And then after 3 months, these side effects seem to, for some women, go away. Maybe some fatigue, something like that for some women. For other women, the side effects are crazy. Everything from, swollen legs and rashes and, all kinds of crazy stuff. How do you deal with that, the idea of onboarding a drug, getting the drug onboarded and dose reductions, and how did that play into your research? Was there anything that popped up that was unusual, or should that be, and I know that there was a sample of what you did, and I'm really interested in this for women with ovarian cancer who are getting these PARP inhibitors. Are there some specific things that we could be kind of tweezing out of this and teasing out rather that have to do with that onboarding process?
Yeah, I think that's a really good question. Well, the very first thing that comes to mind with onboarding is, what are the patient's unique attributes? And, that's in relation to the treatment and also to the dose. With that said, something very interesting just happened with regard to onboarding with the drug called neratinib, which, you know, it's a fairly new drug. It's used in combination for certain types of MBC. Dr. Hope Ruga on our advisory board was a key participant, advisor in a clinical trial that investigated starting neratinib actually at a lower dose in this trial and working their way back up to the standard dose because the diarrhea was so bad among patients in the real world. And actually that was so successful that now the labels are going to be changed for neratinib to start well and titrate up. That's the first I've ever seen of it. Janice brought that to my attention. I'd actually read about it the day before Janice, you said that. So I think that the onboarding process is starting to be looked at. But back to your earlier point, we don't know how patients are going to react after the first dose or even after 3 months. We can't predict that. And that's why we're saying weigh everything up front. You could always titrate up if you want. And in fact, in the oncologist survey, I think over 60% of oncologists titrated up after starting patients on a lower dose. So I think that's wise just to take all of these factors into account at the beginning. And I will say, I'm going to hone in on BMI for a minute, because that's kind of a pet peeve of mine. The average BMI of an American adult female is 29.6. So we could surmise that, you know, patients in clinical trials who are adult American females are somewhere around that on average. So that's the group of people on whom the dosage is tested, right? And the side effects are evaluated. But some of us are way higher in our BMI, and some of us are way lower. Like mine's 18.5. And yet, for many drugs, none of this is weight or, you know, kilogram per, you know, whatever, body squared. It's not adjusted for BMI.
I think that's
all of this needs to be weighed into.
I think that's a great point, Anne. And the other challenge to that is we do have studies that actually say that higher BMI can lead to more severe side effects as toxicity builds up in the body. But the comparator that you just used, which was average BMI across the country, would be really interesting, because we know, based on all of our other efforts, that the demographics of individuals who participate in clinical trials is not representative of across the country. So I love that you brought that up, because I think that we're not always comparing apples to apples, if you will.
And again, in clinical trials, bottom line, the participants are subject to rigid inclusion and exclusion criteria, right? We're not. We're in front of the doctor. Here's the list of treatments.
Yep.
Very different scenario.
You can't have this level of comorbidity to participate in the trial, yet in the real world, you know, people do. So I think that's a great point. Just want to let everybody know we're closing, you know, the end of time. We've only got 8 minutes left. Anne has graciously allowed us to record, so I will share this with people who are not here. I'm stopping the recording right now.